It was again almost very similar to what my pulse showed. I mean, that's what the request from Johnson and Johnson was, and I'm also showing a catalyst femto laser, subsequently using a Signature Pro, and then implanting a Synergy. This is the first eye of the patient. He doesn't have any astigmatism. It's a simple, straightforward grade 2-3 cataract. His uncorrected visual, best corrected visual acuity was about 612 parts. And otherwise, there's no associated comorbidities, reasonable expectations. And that's the kind of patient we always go for this multifocal. And as was being said, our experience with this energy is also quite good. And I'll start the video now. Basically, as was being mentioned, it's the liquid interface, and that's the big advantage in the sense that there's no distortion of the cornea. One thing I would like you to concentrate on the multiple pupil rexis options that we have. And most often the video started. We just align it exactly. And this is a slightly smaller pupil. And this small adjustment is something I would like you to look at, in the sense that it was less than 4.6 millimeters and was what I was getting. And so I go on to pupil maximized zone. Normally, the machine default setting is that it needs at least 500 microns of offset from the pupillary margin. But here I'm manually adjusting it so that I get almost a full 5 millimeter rexis. And as you can see here, usually it's aligned to the capsule, but in this situation, I align it to the pupil, maximize it, and enlarge it to get the usual rexis size of 5 millimeters. And as you can see over here, I'm using basically a 4 segmentation, a quadrant, and creating a grid pattern of 500 micron each, and it's usually 3 repetitions. And I always combine it with an arcuate if there is a significant astigmatism, even if it's at 180 degrees, I do double arcuate. This patient did not have any astigmatism, and though I have been using these lasers for quite some time, I almost completely gone back to the manual incisions as far as creating incisions is concerned, because I believe that the incisions you get with conventional cataract surgery with the manual incision that you get with a small limbal bleed is a great way to go. As you can see here, usually I aim at a 5.5 millimeter rexis when it comes to my manual rexis. Here, all the laser machines I aim at 5 millimeters, simply because I find that invariably there is a little bit of retraction that takes place as far as the final rexis size is concerned. And let me get this video running. And my usual side ports is what I do first, and it's usually 70 degrees away from my central port. It's always a temporal clear corneal incision, a 2.4 millimeter incision. Initially, it was always 2.2 millimeter, and now I'm using a 2.4. And as you can see, that's a little bit of intracameral xylocaine that's going in. That's why a little wince of the patient. And then subsequently, a 2.4 millimeter incision being created. I find that the astigmatism induced by these incisions is practically non-existent, just about 1.1 centroid value, as we have discussed on multiple occasions. And initially, I used to just go in and simply pick up the capsular rexis. But occasionally, in spite of the fact that most often it's free-floating, occasionally there are additions. So nowadays, what I do is to just go in with go in with a Sinskey hook and gently gather up the rexis in the center. I find that this, instead of pulling on the rexis, if I do this, the chances of getting a rexis extension or tattoo, though it's extremely rare, is non-existent. And even if it's a mature cataract, I stain the capsule and then do it. And now the hydrodissection part comes, and I just usually do a multi-quadrant hydrodissection. But in simple cataracts like this, maybe a single quadrant is enough. I use dispersive viscoelastic quite commonly, but in simple, straightforward cases like this, that HPMC does very well. The only thing is I keep filling and refilling. You can see the air bubbles being left out so that you diminish any intra-lenticular pressure being building up. And that's again viscoelastic, removing all the air bubble and just using plain HPMC in this case. You can see my settings over here: aspiration of 36 cc per minute, vacuum of 550, power of just 40%, and I have a overlay of 6:9, And so it's extremely, please to concentrate on FX power that's being used. And mind you, that's not EPT. It's one EPT is 1/10 of that. And if you want to convert it to CDE, that's 1/5 of that. So basically, it's a combination of longitudinal and ellipsoid movements. That was just the cortex and the epinucleus being removed. Usually, it's not even chopping, it's just dividing along preformed cuts that have been made with the laser. As you can see, there's absolutely no energy being used. It's all being done in the foot position 2 itself. And even in that, I don't have to go all the way down into the vacuum. It's just a gentle nudge on the lens, and then subsequently creating these divisions. I would have liked to have operated on a more difficult case, but since the request was for a laser and a synergy, I had to settle for a more garden variety of case, but there are several learning points in this also. So that's the nucleus completely divided, even though, and you can see the EFX is just zero, absolutely no energy that's been used. So even the chopping can be done in these grade 2, 3 cataracts without the use of any power at all. And subsequently, as you can see, I always refill with a viscoelastic, especially if I'm using HPMC, because it just flows out during your initial maneuvers. And that's just the quadrant removal. And here I'm using 8x4, and you can see the energy again is 50%. I'll actually subsequently drop it down to 40. And you can see the extreme stability of the anterior chamber, in spite of the vacuum being 500, aspiration being 40. The bottle height is 80, which translates to an intraocular pressure about 60. I found that even with lower bottle heights, this instrument phaco system works quite well. And you can mimic almost the kind of settings that you use with a active fluidic system. And it's possible to get away with a much lower bottle height in these situations. And you can see the center of my phaco tip almost is, the phaco tip stays almost in the center. I just have to nudge the nucleus into the anterior chamber. It's obviously anterior chamber phacoemulsification. Is the initial bisection that's all taking place within the bag. Then subsequently it's in the anterior chamber, but you can see that it's angulated. It's happening in the iris plane or in the supracapsular plane, well away from the endothelium. And the amount of energy that's been used, as you can see at the end of the surgery, I think maybe about 15 or 16, which means it's about, if you want it in EPT, just 1.6. And if you want in CDE, it's about 3.2. I think that's extremely good for a reasonable cataract like this. Of course, it has been pre-treated with laser, which also helps. And now coming on to irrigation aspiration, I completely with you on this, Gaurav. I'm a great fan of bimanual irrigation aspiration, especially the kind of access it gives to almost all segments of the capsular bag, especially in the subincisional area, is absolutely great. And I use this sandblasted aspiration cannula, which is provided by Johnson & Johnson. And I think it not only, the irrigation just stays beyond the incision, and you can see the ease with which I'm able to approach the subincisional area and almost 360 degrees clock hours, and able to remove all the cortical matter. And whenever I feel that there's a bit of capsular polishing is just necessary, about which I'm quite meticulous, I go ahead and just switch over to a cap vac mode, where you'll see that it's right now it's only 6 cc and 20 mm. And if there are small segments of capsular fibrosis away from the optical axis, I really don't mess around with them, because they really don't interfere with the vision. Whatever PCO occurs is because of proliferation of cells from the equator. So just for the sake of a video, if there are small dots of opacity left behind, as you can see here, I'm not really going to waste my time or risk removing them. But as far I want the central visual axis to be absolutely clear. And when it comes to the nasal quadrant, you can see the ease with which I'm switching my hands is more for any youngsters who might be watching, and going on to using the advantages of bimanual mode. And the cortex is being completely taken out, and that's a small strands. And whenever I want to do a bit of capsular polishing, I switch over the cap vac mode, and that's can be done with the foot switch itself. I do not routinely polish the rim of the anterior capsule, especially in situations like this where you have an adequate rhexis. And I do not think that really adds anything. It's only pediatric cataracts or pseudo exfoliation, small rexes where the polishing of the rim is necessary. As you can see, I'm fairly meticulous about polishing of the posterior capsule. At the same time, if there is a recalcitrant small fibrotic patch, not in the central visual axis, I would rather leave it alone. And that's the end of the phaco and irrigation aspiration. I'm also going to be using a synergy lens. It's not a trifocal lens, but it's something of a combination between a EDOF symphony lens and excellent bifocal diffractive lenses that we had. One of the lenses that I always enjoyed using was the diffractive +4 diopter rad, which gave an excellent near vision. But then as far as intermediate vision was concerned, it was non-existent because it was at 25 centimeters. Then with a 3 diopter rad, it was 33 centimeters. Then came the Symphony, which was excellent for intermediate vision. But then as far as near vision was concerned, it was a little deficient. And that's the reason you had to have discussions about mix and match, etc. And in the second eye, trying to titrate the power. This lens can comfortably go in through a 2.4 millimeter incision, and even a 2.2 millimeter incision is good enough. And it's made of the same wonderful hydrophobic acrylic material we are so widely used to. It has the chromaline technology, limiting the amount of chromatic aberration that's induced by the cornea because of the negative chromatic aberration that has, apart from the highest Abbe number that's available in the industry. And it also has a asphericity of minus 0.27, and which almost completely neutralizes the spherical aberration on the cornea. Combined with the neutralization of the chromatic aberration and the spherical aberration, these two potentiate each other, because of which the quality of vision is extremely good. And the fact that it's a continuous range of vision lens, which offers almost a continuous vision right from 33 centimeters to infinity. Actually, nowadays, I'm not talking about mixing and matching or the second eye surgery. Most often, it's bilateral synergy implantation is what we are looking at. Mind you, even with trifocal lenses, we have been extremely happy, and that's what we are getting at. Maybe it's good to have choices like this. And having said all this, it's again, as far as counseling of patients is concerned, it's no different from what we do as far as our multifocal intraocular lenses are concerned. These lenses also have diffractive rings of 15 in number, and since they are right up to the extreme periphery, even in dim light condition, the vision is good. But this photopsia is a possibility, and the company also does not claim that this photopsia doesn't occur. So as far as counseling is concerned, continue doing what you are doing with multifocal intraocular lenses. But though you know, and your patient will realize later, that this functions much better than the multifocals that we're used to. Thank you so much.